can see in this photo, you see the nice arch of the teeth. The tip of that tooth is actually a nice position, but if you look at the root of it, you can tell, you can see from that angle, but this tooth is actually completely, the root of it is completely tipped outwards. Because of the malposition of this tooth, because it's completely tipped out, there's no bone on the outside of that tooth. Hence, it's actually no class 3. There's no bone on the outside of the tooth. Therefore, it's not predictably treatable, unfortunately, without pulling the tooth back in with ortho. That's why when you guys are doing the ortho cases, the Invisalign cases, it's important that you do bodily move the root inwards rather than tipping the roots outwards. Once it gets to a situation where the root is that prominent, when it's completely moved out of the buccal plate, it's very difficult, not impossible, to try to treat these cases. What should you tell your patients if they do have recessions? Like, hey, what do I, you tell me you need a graft, but how am I going to feel afterwards? Well, in terms of the area that we're working on, it's going to be a little tender, it's going to be a little sore for about 24 hours. We do the procedure under local anesthetic, we give them pain medications, usually fine. I usually tell my patients to take the pain medications every 4 to 6 hours, immediately before they leave the office, and for the first 24 hours. The roof, that's a typical area where we harvest graft from, is going to feel like a pizza burn. If you've eaten pizza in the back, you kind of scald the roof of your mouth, that's what it'll feel like for the first day or so. It's more of an annoyance rather than a discomfort because we put stitches in to help it heal. People's tongues are going to play with the stitches, and it's just a little more of an annoyance rather than a discomfort. There's going to be a little bit of swelling, a little bit of bruising, and we put ice on the areas on the outside just to make sure it doesn't swell too much. Sutures, they fall out. They're fully resorbable. I usually see the patients within 2 weeks to take the stitches out if they haven't fallen out anyway. So I do follow up with the patients. The graft itself, once it heals, once oral hygiene, once the maintenance by the hygienist are completed, it usually is a permanent fix, a permanent solution. And it can help to reduce sensitivity. It'll never get rid of 100% of sensitivity, unfortunately. Nothing in life you can guarantee 100%. Sensitivity is one of those things you just can't guarantee that it'll be completely gone. It will be much better than it was before. However, you still might have a little bit of residual sensitivity. The purpose of it is basically to improve the aesthetics, to gain tissue that you lost, and to improve the resistance of recession down the road as well. Next issue that I want to talk about is actually the keratinized tissue. The keratinized tissue is basically the tightly bound down tissue that's around the neck of the tooth. That area of keratinized tissue is actually very helpful in the sense that it makes it very comfortable to be able to brush, to be able to floss. When you lose all that tissue, whatever is left, the loose mucosa on the bottom is actually very delicate. If you get any inflammation in that area, it can progress quite rapidly. Ideal situations, you have 2 or more millimeters. So when you're doing the exam, you have to check the recession, but at the same time, you need to check how much tissue is actually left in that area. When you have a situation with no keratinized tissue, the gingiva is very, very thin, and the other thing that can actually affect the prognosis is the frenum attachment as well. I'll show you a few cases too and show you exactly what I'm looking at. Situations end up being a little uncomfortable to brush because the tissue is so thin. It's like, hey, there's a lot of buildup in that area. I have difficulty brushing it. Well, it's because you don't have enough keratinized tissue in that area. So I'll just show you a few more cases. So this is a situation where you can see that you do have some recession around the canine, but at the same time, if you're looking down towards the vestibule, he's got plenty of keratinized tissue on either side. However, right where the canine is, he actually doesn't have any of the keratinized tissue. You can tell, it's kind of hard to see in this photo, but you can tell where the mucogingival junction is, which delineates the keratinized tissue from the unkeratinized tissue, or the loose mucosa. When you draw a line, you want to measure at least 2 millimeters in these areas. However, if you can draw a line where the mucogingival junction is, it kind of dips down, and around the canine especially, there's no keratinized tissue at all. Typical cases that we generally see these issues are actually on the mandibular anteriors because the tissues are very thin there. The other issue is that you have a frenum pull in the middle. You see in these 2 teeth, you know he doesn't have any recession. However, it's uncomfortable. You can see how swollen it is. Because it's uncomfortable to brush it, you're going to get plaque accumulation, you're going to get inflammation, you're going to get possibly further recession. Next slide. Here's another example where you do have a little bit of recession. You have no keratinized tissue on the 3-1 and the 4-1, and you have a very high frenum as well. Next case. And this is a situation where you can see how wide the frenum is. It's actually, certain situations, actually a very narrow strip. This one's actually very wide, and you do have a little bit of recession. The important thing is that you don't have any keratinized tissue whatsoever. And we were talking about frenectomies earlier. Sometimes when you just do this excisional frenectomy, they usually do reattach, and sometimes they reattach in much wider. So that's why what we typically do in these cases is to thicken up the keratinized tissue, get rid of the frenum, and the graft is actually a slightly different graft. It will actually help to to preserve that situation. So the treatment of mucogingival defects is that it's a free gingival graft that you're using as opposed to the connective tissue for the root coverage. These are situations where you want to increase the zona keratinized tissue rather than covering the root. The purpose of it is we could alleviate the freedom with it, you can increase the keratinized tissue, and as I said, this will help to prevent recession down the road. It makes it more comfortable for the patient to brush and clean. This is a situation, what do these look like after the fact? This is 1 week. This is very early. The other case I showed you was 2 weeks. When a patient comes back after a week, looks pretty nasty, doesn't it? Some patients compare it to looking like a hamburger. Some patients say it looks like oral cancer. It does look pretty nasty in the sense that the graft looks a mixture of red and white, and there's just little bumps and everything. And the one on the right is where one of the sutures in place. This is actually normal. This is actually healing very nicely. Over the course of 6 to 8 weeks after, things will blend in. The tissue will actually blend in quite nicely. This is another situation, when you guys are doing crowns, you're doing bridges, and there's a little bit of irritation around the tooth. Before you're prepping the tooth for a crown, for instance, like this tooth, you can actually increase the band of tissue in that area by doing a free gingival graft. That way it's a lot more comfortable for the patient to brush and floss it. It's actually easier to take the impression as well. And the last thing I wanted to talk about is dental implants. Dental implants are basically when you're missing a tooth. You want something to replace the tooth root. Titanium implant works very predictably. It's basically a permanent fix. The long-term studies have shown that over 50 years, the implants placed 50 years ago are still around today. And a lot of times they actually outlive the patients. So it's very highly predictable. And it's done, however, when you do the implant, you can't just put the tooth on it right away. You need to wait for a period of 2 to 3 months for it to heal. After the implant is placed, the dentist does the crown. This is a case where the patient is missing the lateral incisors. You can see that she has braces, and these teeth are actually just denture teeth that are kind of glued onto the wire. In this case, you can tell in this situation here, we've done a little bit of a touch-up with the gum work, and we also placed the 2 implants. And this is the models. This is what the dentist will do. They'll take impressions. You can tell the implants in place nicely as you get a screw retaining prosthesis. And this is the finished case with the nice gum contours. You can see the nice crowns as well. So she was a 22-year-old female. This should last her the rest of her life. Crowns might need to change as her natural teeth change color. However, the implants are there. They're permanent. You can always swap out the crowns. So once again, all the information is contained on the website. Check out the forums, all the post-op forums, all the photos, all the cases, descriptions are all online as well. And I'm here to help. Let me know how I can. And hopefully, what I've presented will try to make your jobs a little bit easier, make the dentist job a little bit easier as well. And if you guys have any questions at any point in your careers, come find me, send me an email, talk to me. I love talking about this sort of thing. So I know you're probably out of tape, so I'll just end it there.
Still going.
Thank you.
Continuing with, seriously? Continuing with, after we determine, so hygiene will basically, okay, so patient's going to come in to the operatory, hygiene's going to do whatever they do, and if they have an area of concern, the dentist is going to walk in and take a look. Or during the completed oral evaluation where the patient is in the chair, where the dentists are going to be looking for the stuff that Dr. Thang already mentioned. So how do we go and proceed from there? So now, usually all the stuff that we're talking about relates to one specific site. There could be multiple one specific sites, but it's one specific site. So for example, let's say if 233 needs has recession, what you're going to do, hygiene or assistant or doctors, is you're going to highlight 233. And then there's going to be a button here set up. Right now it's not set up, but it's going to be this code right here. Treatment. It's going to put a box around the tooth, okay? If there are multiple teeth that have an area of concern, for example, there could be recession on that tooth, this tooth could need crown lengthening, this tooth could need something else. You highlight all of them, all right? And as I said, there will be a box set up, and you'll see it's a box. So then, those are the areas that are going to be treatment. That means the dentist has determined that this person should go to visit Dr. Thank for a periodontal evaluation on those specific sites. Now, so this is at the hygiene. What happens is You'll double click the area, all right, and you'll say what it is in that area that needs to be evaluated. So this one is recession. Let's say 2, 3, whatever is MGD, mucogingival defect, right? Okay. Now, what has to happen as well is after you enter what the concern is that the dentist wants evaluated, you're going to click on the bottom here, refer to doctor, and refer to city view. Where is he?
He's right there.
Fine.
Thang. There we go. Okay? To Dr. Thang. You have to do this for every tooth though. The reason is we want to keep track of things, okay? So that we can talk to patients when they come in. When patients come in after, so now, patient comes in for, so now we're going to continue with the referral process, but let's say 6 months down the line, they come back for their hygiene. This is going to pop up and you're going to see red boxes in the areas where there were concerns. Now, the hygienist, if it hasn't been entered already, and I'll tell you guys about that in a second, is going to sit down and evaluate and say, was treatment done, wasn't treatment done? Say treatment was done, but somebody didn't change that. If treatment was done, you'll double click existing other providers where you'll click it, and it'll change the color, okay? So then that will give us the heads up from now on. Every time the patient comes in, we can evaluate that site and see and spend a little bit more time to make sure that the therapy that they underwent is getting a little bit more attention than everything else to make sure that there's a greater chance of success, all right? If the other two are still red and therapy wasn't done, on periodontal therapy wasn't done on that yet, that gives us the opportunity to say, so where are you at with it? What are the concerns? How can we help you get the treatment that Dr. Thang recommended, okay? So it's a little bit of a dialogue. So now, we go back prior to that 6-month re-eval, and we've determined that these areas are sites that Dr. Thang should evaluate. We've entered the sites into the treatment plan. Now, on everybody's desktop, there's going to be this form. Not that form. Damn it, where is it? Oh, okay. Press pause on your camera.